All right.
Sneeze, Maria.
So I have the topic today of systems-based practice I generally give most of our core competency lectures, and I always start off by asking, what are the ACGME's six
Pimps.
core competencies? Okay, I'm not gonna, no. Systems-based practice, it's not gonna be included in this one because that's the title of the presentation. So, Nalene. There's 5 to choose from. You got the easy one.
Pimps.
Stephanie, off the computer, all electronics away.
I think one was like patient-centeredness or something.
All right. Brandon.
Medical knowledge.
All right, so it's always pretty much answered in the same order, so when I put my slide together, it's in the order that it's generally answered. Luke.
Interpersonal communication.
Oh, you skipped one. Yes, interpersonal skills and communication. Scott, put your phone away, but go ahead. All right, go ahead.
Practice-based learning.
All right. Vega. There we go. That's usually the one after that. And we do have communication, interpersonal skills. Dr. Rujo. Dr. Rujo's got the 6th one. But as the chief, you should know it.
Oh, boy.
You've had the
Where do
most
you start?
experience with these.
What is actually systems-based practice, medical knowledge. Here. Which one did they say?
Dr. Rogers, do you know?
Professionalism.
Correct.
Oh.
Professionalism and
Yeah.
then practice. This is usually the typical order that y'all answer them, so that's why I kept it in that order.
I think you
So-
should put it as pimps though, not one.
So today, we're just focusing on the systems-based practice. I'm not gonna go over this in detail, because I know y'all have this memorized, but this is actually from the ACGME literature about how systems-based practice should be incorporated into residency training. The parts we're gonna be focusing on today are down here. About working in interprofessional teams to enhance safety, improve quality, and participate in identifying system errors and in implementing potential solutions. This is also all from the ACGME, and today it's mainly about understanding the systems issues with reduction to medical error. And then lastly, here, participation in interdisciplinary teams. So whenever we, and Dr. Barr, we need to fill out this paperwork talking about people participating in QI projects or patient safety committees. That's what we're talking about, because it really should be at an interdisciplinary approach. It shouldn't just be us sitting here for M&M. We just talked about 2 or 3 different instances. Well, was anesthesia aware of this? Was the emergency room aware of this? And this is why it's important to talk about this outside of just this group. All right, so these are the goals that were set, or the learning objectives that were set for this specific lecture. And it was mainly to discuss, and I am modifying that to kind of say to understand. Because we can talk about it, but if we don't comprehend these different aspects, then we really haven't done this topic justice. And a lot of this some of it's basic, and that it's a lot of just terms and definitions, but they're not straightforward. To me, as I'm going through it, I was looking for examples, analogies, things like that, because it's not straightforward. So first, we're going to talk about the nature of adverse events. So, what's our guess about the percentage of the general public that has experienced medical error in their own care of a family member? General public, not at East. General public.
25%.
50%. Approximately nearly half of all the public has had a patient that's had a medical error in their own care or of a family member. Specifically, some of the studies that were quoted within the readings talked about medication errors, and about half of medication errors were determined to be secondary to distractions. And when they talk about medication errors, they talk about timing issues, route issues, so something's supposed to be given IM and it's accidentally given IV. Wrong medication, wrong dosage. I mean, wrong medication, wrong dosage are probably the more common ones that we see. or medication given, to the wrong patient. So a lot of times it's distractions, so someone's supposed to get their dose at 9 o'clock, they don't get it till 11 because of whatever happening on the floor. Other things that of course are always cited, workload increases and staffing issues. And we can say, oh, well, people are, maybe just complaining about things, but we talk about it all the time. And the increase in documentation that the nurses now have to do on the computer. And so all this stuff is being mandated that they record all this information that may actually hold up some of the dosage timing and such. Dr. Russo, you had a question?
Well,
Yeah, I found like with the new computerized system, where you can just open a chart and you put orders and any, the patient in the computer, it's a lot easier to actually enter your own medication on the wrong patient, because you think you're in the one patient and you're not in the patient, as opposed to the old paper charts.
And I've actually seen that where these orders will come on saying, oh, you approve this order, the other thing is verbal orders. And I'll get these verbal orders and I'm like, I have no idea who this patient is or this medication, and I know I didn't order it. So that can happen as well. Stephanie, you had a question?
No, it's funny that we're talking about the nursing things, and a nurse yesterday was talking about how, it's gotten so, and she wasn't complaining, like we were just talking about it, and she was like, it's the documentation, while it's good that we're documenting everything, it's actually taking their eyes and our eyes off of the patient. So, while she's sitting there inputting whatever they have to input, which is beyond my knowledge of what they do, but they do a lot in the computer. I think they are taking their eyes off the patient, so that will lead to a medical error in itself.
Well, it's interesting because, the current setup, especially in Ginsburg, is they have those little niches and then they're supposed to be able to see those two patients. That's great for ICU patients if they happen to have those two patients, but that almost never seems to happen.
Right.
Or you end up having 4 patients on the floor and yet you can only keep your eyes on 2 patients. So yes, 50% was the answer. One of the other areas that was quoted within the reading was talking about prevention. So what amount of errors are considered preventable? So it actually says out of early surgical adverse events, 74% were considered preventable, 65% of non-surgical adverse events, and then 90% of late surgical failures. So they didn't actually get into the definition of what qualifies as which, but what they're basically saying is most things can be preventable. And when we talked about this, when we talked about M&M this morning and talking about blood pressure, then, maybe it was preventable. Maybe if the systolic had been monitored closely and continuously and they never fell below 130, maybe that person wouldn't have had a stroke. This is interesting, and Nalene will probably appreciate this, but what they actually said was that our US rates, our benchmarks, we would have to reduce our rates of adverse events by 1/3 to match Germany and the UK. So the US is way behind in this. So one of the things that we also want to be able to understand is the definition of terms related to patient safety. And this is where I found things, like I said, as I was kind of reading through this, and hopefully it shows up, there's a lot of terms here. They're all very closely related, which is, I think, kind of what makes things a little bit difficult in understanding this. So an adverse event is an injury, okay? So an adverse event could be an adverse side effect, it could be an error, and you see that right there. So a preventable adverse effect is one that is attributable to error. Unpreventable one would be one that, we couldn't have predicted it. We couldn't have prevented it with our current knowledge. So that might be more related to either a latent error, so maybe something that we didn't know was an issue until all of a sudden there's an error, or maybe a medication side effect or some side effect of implant. And y'all can read these here, and I'm sure y'all read them in the readings last night. But the one that I think is probably the most interesting and probably would help us long-term from actually changing the system for patient safety is the near miss. And how many times, and y'all can probably think of something that has occurred in the past 2 weeks that was a near miss, okay? To where someone almost got the wrong medication, or, someone almost operated on the wrong side, or something like that. Those things happen, And it's kind of one of those things where you catch it ahead of time. It may be 30 seconds before it's about to happen, it may be 3 hours before it's about to happen. But you catch it and then usually we forget about it. Usually we say, oh, well, I'm glad that didn't happen, and then we go about our day. But I think that's actually where we should learn the most from, is our near misses, and then potentially be able to change behaviors based on that. This is actually what they talked about, reportable events. And specifically looking at surgery, I mean, of course, wrong body part, wrong patient, wrong procedure on a patient, retention of a foreign object. And do y'all know, so we talk about sponge counts and is the count correct? So when there's a retained instrument, do y'all know the percentage of the time that it's actually a correct count?
100%.
Not quite.
80.
It's about 70 to 90%. So 70, in the literature, 70-90% of the time, the count is actually correct, and yet something was left in place. So it's always interesting whenever they, say, stop, we haven't finished counting yet. Because it is,
That's assuming they know what they're counting. So what I thought was being asked, if it's an instrument or piece of an instrument or equipment that is inadvertently retained, the staff may not even know that it exists, let alone should be counted. So in that circumstance, yes, the count would be correct 100% of the time.
yeah,
So for instance, when a Penrose drain is cut, it goes from a count of 1 to a count of 2. So they have to account for 2 Penrose drains, no matter how big or little the piece is. But they know that that happens. But if it's a piece of a cartridge of a staple device that they have no familiarity with, then it's an unknown.
The protector, the Bobby tips, it's
Yeah.
not countable, there's all sorts of things that.
the plastic pieces that connect the trocars.
Yep.
But granted, that's laparoscopic, but if someone doesn't throw it off and we convert to open, what's to say that doesn't fall off the Mayo stand? And it's interesting you said that, because when I was in training, and actually a fellow at this institution, we were putting in a newer device, and one that the OR staff was not familiar with, but the surgeon was. And it actually involved suturing in leads, so it was a lap intera, so it was suturing in leads to the stomach. Well, he opened the device on the back table, and I actually was suturing it in, and he was scoping from above. Everything was in place, we tested it, everything was great, we left the OR. Well, as I sat down to dictate the case, I went, we never removed the needles. And the patient was already in recovery. So we had to bring the patient, luckily they hadn't woken up completely, but we brought the patient right back into the room, went back in, cut off the needles, and we're done. But the count was correct, because the surgeon had opened it up and had not counted the needles on the leads as part of the count. So at the end of the case, the count was correct. So, and it was a reportable event, and it was reported. Luckily, the patient had no ill event from it or no adverse event, but they did have to undergo a second round of anesthesia within 20 minutes.
Is it?
So when technically does something become reportable? Because
That's what I was gonna ask.
I was in
When we report it.
case, well, I was in a case where we did a bypass, the chest was open, closed, the count was wrong. X-ray was taken, patient never woke up, never left the OR, X-ray was taken, saw the sponge, opened, took it out, closed again, count's fine.
So it's reportable as soon as the skin's closed.
Correct.
If you find there's an incorrect count or get an X-ray, somehow determine there's something retained, as long as the skin is not yet closed, or should say closed even completely, then you're okay.
Well, we closed the sternum, we didn't close the skin.
Well, then you're okay.
Well, then you're okay. Yeah.
So like they would
I've
say,
actually,
need one stitch.
I've
until
seen
it's-
people literally put all the staples in but one,
Yep.
and waited until there was a correct count.
If you're Dr. Vidula, it could be either way. I mean, using like 100 staples in one.
Yeah.
They'd be like, well, wait, I wasn't done yet. But
I need my 4th stapler, please.
See, like, for example, like 2 days ago, we were doing a big use case with a book bolter and everything, and all of a sudden, like, there's a ratchet and one of those things, so the book bolter, that's completely missing. Now, the nurses, like, well, we had our account correct, it's like, well, it's, you know, it's like, I don't know what this ratchet is, it's not inside the patient. We waited literally an hour, because it's the end of the day, there's limited, you know, x-ray techs, to be able to wait for this patient, which just had a huge liver resection, to be able to get an x-ray, to actually say, no, it's not there, you know, it's like, is that reportable, that the nurses messed up, you know, the patient could
No,
be in the ICU?
No, because it's not a reportable event, okay, so reportable, and we're gonna talk about this towards the end, but it's not supposed to be punitive, it's not supposed to be a finger pointing thing, it's supposed to be looking at it from a systems approach, okay, so maybe we need to figure out a better way for X-ray to get over in a timely fashion and take the images.
So there's several points for that case, but when we talk reportable, we're talking incidents that are reportable to the state.
Yes.
That's a whole different level.
Oh, yeah, no,
So it's
no,
all
but at
different
least
level.
internally.
Well, internally, you're correct, but and that's what this whole systems-based practice is. Who do you report it to internally, and who we're gonna take ownership and be responsible for clarifying this?
I mean, it's like an extra hour of work.
I understand, but so the point is, who did you speak to about it?
Well, I mean, at the end of the day,
Besides
like,
us.
you know, like,
Who do you speak to about it?
well, I'm not yet, I mean,
Well, then nothing's gonna be done.
well, yeah,
So the first responsibility is recognize that there's a problem,
yeah.
and then have someone help you figure out how to resolve it. So the systems could approach this from a couple of different ways. X-ray availability, responsive time, all that. Then the other issue is, how do we know that all the kits are correct? That everything is in fact there? So is that they allegedly checked this instrument count beforehand, saying everything's there. The real issue is most of everything here most of the time. And that's not accurate enough. And it impacted your case,
Where
but
was-
that's
where
where
was
the
the
problem occurred.
Well, nobody ever found, but I mean, we took the x-ray, it was not inside the patient, so it was like, well, I don't know.
So
But, I mean, it
whoever's
had-
in charge of the OR with packaging of kits and all
Central
that,
Supply or down.
whoever is in charge, that's the person who has to know about this and take responsibility and ownership of getting this to the point it doesn't happen again.
So like Dr. Barr said, this is a list of what needs to be reported to the state. So, you know, some of this stuff doesn't necessarily pertain to us on a regular basis as far as surgery. But one of the things that I thought was important is stage 3 or 4 pressure ulcer acquired after admission.
Nice.
We see that a lot.
We
We
went
see it on a couple of different, you know, pathways. One, we've had it on our own patients. And then on the other side of things, we sometimes are consulted on these patients that were medicine patients or neuro patients that are bedridden, and then we are now debriding these ulcers. So we actually see them in 2 different routes. And I don't know if they're being reported, okay? That's something that might be interesting to look at, because we've talked about it recently, and the morbidity involved with some of these. How frequently are we giving patients in or loop colostomies so that their decubitus ulcers heal? I mean, that's a significant morbidity associated with this, besides the debridements and the flaps and everything else that needs to be done, the length of stay being increased. So anyhow, I'm not gonna go through all of these, but it basically is broken down to surgical, product device, patient protection, care management, which is, so ours is probably gonna be more focused on surgical and care management. And then, you know, we talked about this right here, patient death or serious disability associated with a fall. Remember our patient several months back who was in the ICU and managed to fall out of the bed and fracture his hip? I mean, you know, you look at those things, but that's something that was completely preventable. So also, our third goal is to understand the nature and characteristics of systems. And I thought this was interesting because when they talk about systems, what is a system? And this person defines it as, you know, we work in numerous systems all day, every day, and sometimes it's difficult to see a system. And it's like asking a fish to describe water. It's easier to be aware of the system when the system fails. So all day, we're working through a system. You know, our patient comes in, they go to pre-admission testing, and then they go to pre-upholding, and then they meet the nurses there, and they need anesthesia, and then they go to the OR, and then the PACU, and then, I mean, there's multiple systems involved with that. So this also just defines systems a little bit more, but mainly each part could affect the whole. And they actually define this, and I tried to come up with some cute little equation for it, but it was too complicated for an equation. But essentially, it's the probability of a system failure is the error within each step times the total number of steps, and then the degree of coupling. So when they talk about coupling, they talk about things being loosely coupled and tightly coupled, and that matters because loosely coupled systems have fail-safes, there's redundancy, there's checklists, so that things actually, if something goes wrong, there's a potential to catch it. Things that are tightly coupled, if something goes wrong, then you start getting the cascade of events. There's a cascade of events involved. And so that when it's more tightly coupled, then you're more likely to have an error. So, relation of individual performances to surgical error. And this is where I thought got really interesting. So it talks about performance, and that's performance of us. So, some of the stuff we were looking at before might not be purely surgical. This is really talking about surgical performance. So we have skill-based, rule-based, knowledge-based. So skill-based is when you're kind of on just automatic, where you're just focusing on your long-term memory and you're just going through the steps, tying knots, throwing stitches, whatever. Rule-based is more about, trying to take care of a patient based off of your own rules, okay? So it's usually based on prior experience. So, well, normally a patient with diverticulitis and an abscess comes in, we get IR drainage, okay? So that's kind of one of the rules in our head. And then knowledge-based is actually where we really have to sit down and kind of think it through and focus on different options, because maybe it's not something we've seen before, or the patient's, got some comorbidities involved. And this is what they actually talked about in this table, is again from the reading, and it talks about common modes of failure associated with specific types of performance. And some of the stuff, I don't even know what some of these words mean, but I thought, some of the other ones, obviously omissions following interruptions, so that's skill-based. So you're in the OR, you're doing your normal routine, somebody comes in to talk to you about a patient, or the pager goes off and you answer in a question like that, and then you have to go back to what you were focusing on before. It's easy to miss a step, okay? So you skip one step. Maybe it's that, we didn't take out the Penrose or something like that, okay? So these things can happen. That's usually defined as slips and lapses for skill-based, and then rule-based and knowledge are actually considered mistakes, okay? So with rule-based performances, it can be that you didn't use your good rules, or you used them in the wrong way, or maybe your rules are bad. So, and I've seen this before where a resident says, well, we had a patient like this and we did this and it worked. Well, maybe it works 1 out of 100 times. That doesn't mean the next patient comes in, that's what we're gonna do. Or maybe you were instructed poorly and you just got lucky with that patient. And it's not a good rule, it's a bad rule. So that can actually happen. Knowledge base, I think one of the more interesting ones to me, and this is not pointing at out of mind, this is pointing at confirmation bias. We are all, for the most part, used to being right or like being right about things. No one likes to be wrong about things. So if in your mind you are convinced this patient has a diverticular abscess or whatever it is, and that's what you've convinced yourself, sometimes when the different test results or different lab results and stuff come back that maybe refute what the diagnosis in your head is, sometimes we still stick to our guns. And everybody's seen this from someone or maybe been guilty of it yourself. When you stick to your guns with the diagnosis and a treatment algorithm that's either in the diagnosis is incorrect or the treatment algorithm's not correct either, but you still stick to it because that was your plan and you don't want to be wrong about the plan. One of the things that's interesting that they said is that experienced surgeons generally make slips and lapses, whereas novice surgeons have the tendency to be the ones to make mistakes. Okay, that makes sense because from a mistake, from a situation where you don't have the knowledge, maybe you're early enough in your training, you don't have well-developed rules, then you're more likely to make a mistake. So the last one is to understand the successes and obstacles to improving patient safety. So, interestingly enough, looking at this, the anesthesia was one of the first ones to actually look at patient safety from a systems approach. So they originally started with a mortality rate of 2 out of every 10,000 patients. They actually got down, after they started doing some of their changes within their systems, got down to 1 out of every 200 to 300,000. And they mainly looked at it from teamwork, practice guidelines, automation, simplification of procedures, and the most important thing is the standardization of equipment and functions. Now, I'm not sure if anyone read the literature or not, but does anyone have an idea as to one of the biggest changes they made was that had the highest impact? If you hit
No
Says
crossword
hand.
puzzles?
No sleep.
the
A ventilator?
So basically, back before there was standardization of equipment, you could actually, within one hospital system, have multiple machines. Because maybe one year, they had, they signed a contract and got these 10 machines. Well then, maybe the next year they worked with a new vendor and got 4 machines over here, or built new ORs or something, and have a bunch of different types of machines. Back in the day, some machines, to turn on the gas, you turn it clockwise. Other machines, you turn it counterclockwise. So they actually would have machines where people were going in between them and just automatically turning it one way when maybe they should have been turning it the other way. So they actually worked with industry to make a standardized machine so that everyone would treat it the same. This is a list of what they determined were obstacles. I'm not going to read through this. Although, I read primitive medical information systems, I have to kind of laugh a little because I think about Cerner and Epic. Although there has been improvement within the systems, there's still a long way to go with that. I think for us, the biggest issue is the time and expense involved. So, Dr. Rougeau brought up a perfect example of, oh, well, who do I report this to? Or I need to report this, but it's been what'd you say, 2 days? And so far, we haven't done anything. And as we get farther out from the event, you're more likely to forget about it, or until it happens again. And then at that point, you might say, oh, well, maybe now we need to do something because we just had our second incident of it. But if you think about it in that way, had you done something maybe on the first one, the second one might never have occurred. So, but it takes time, and it takes personal investment. It takes us trying to figure out who the right person to communicate with is. Or do we send an email and then they respond, oh, I'll look into it, and then you never hear back from them, and then you get busy studying for your boards or whatever else, and then it just kind of goes by the wayside. So I think that that's probably our most difficult situation. So whether or not in the back on the dry erase board, do we need to start every time we think of something that says, maybe we should discuss this with someone, maybe we put it up there, and then one day we sit in here and say, okay, these are all the issues, and maybe we get someone from risk management involved, or nursing, or whatever, and we go through those things. I don't know, just a thought. They spoke specifically about M&M, because as surgeons, we actually not only are required by the ACGME, but we're accustomed to doing M&Ms, and accustomed to coming and talking about errors and how can we prevent them and not have them happen to our future patients. But what they talked about, it doesn't consider all complications, and it's true. Every now and then we'll talk about the wound infection or the urinary retention, but not every time. We don't talk about it every time. And we don't talk about our near misses, which are great opportunities for learning, not consistently well attended. That's true. And a lot of times cases are presented and the attending's not here to speak to the decision-making involved or to speak to the error. That we don't always look at things systematically. We try to, but we can't always account for every aspect of the system that broke down to the error. Sometimes it doesn't involve extensive debriefing of how we could prevent it in the future. We talked about reporting system. One of the most important things, it needs to be non-punitive. And that's difficult because we are all afraid, and our society is afraid to report things if we think, are we gonna be punished for it? Is my attending gonna be punished for it? Is my colleague gonna be punished for it? Are we gonna get sued? So these are the things, and I'm not saying we have a system like this now, but eventually that's what we're gonna need. Anonymous, and there actually is supposed ways that we can report things within the system anonymously on some tab through Insight or whatever that no one can ever find. Allows for near miss events. And then one of the other things they really talk about in there is other hospitals. We deal with that all the time with transfers. So, you know, the hospitals on the coast and the hospitals, you know, out to the west may not report these, even though, because they're sending their patients to us. You know, they're sending their stage 3 sacral D cubes to us. They might not have reported it because now it's our problem. Now we're dealing with it, you know, or their neck fash or their complicated patients or whatever. We're now dealing with it. So there needs to be a way for us to look at it that. From a systems approach, first off, we know human error is unavoidable. Faulty systems allow for human error to injure patients. Dr. Rougeau's example. So someone forgot to put a ratchet into the Bookwalter tray. Okay, it happens. It's, you know, we all make mistakes. So someone maybe got distracted, they didn't put it in there. But then now in the count, for some reason it didn't get counted. And then now this patient's been in an extra hour under anesthesia. Hopefully they did well and they're doing fine now, but who knows? We can't calculate what an extra hour under general anesthesia might actually do to that patient. So the whole point is that systems can be designed that prevent or detect human error before injury can occur. So those are our objectives. Hopefully we met them.
You know, that last part, as important as medicine is, I know that's very highly studied in the aviation world.
Yep.
Is one of the biggest areas. They really do a lot of that research with the FAA and stuff, just because of obviously, you know, one little error, you know, with the mechanic at night or whatever, and it snowballs, and next thing you know, 200 and whatever people crash because of this. But we used to have, every year you have to sit through certain types of safety courses because of it.
And within the reading, there was a lot of mention about the aviation system, and there's always talking about that, you know, the debriefing, the pilots debrief and things like that. And one of the big things that I saw and is about either flight attendants or junior pilots or whoever actually can come and speak to the pilot, and not that they're challenging them or questioning them, but if they see an error or a problem, feel comfortable saying it. And the pilots actually say they want that kind of open communication, whereas I don't think we have all that right now.
Yeah.
I don't think, you know, a scrub tech or an OR nurse or a junior resident always feels comfortable telling an attending, hey, maybe you shouldn't do that, you know? Or times when, you know, Dr. Vega's trying to tell me, hey,
Excuse me, Dr.
your
Vega.
stitch is on the wrong side, and I'm like, whatever, you know? You know, maybe he needed to be a little bit more forceful with me. But he felt comfortable saying something, but I don't. But I mean, no, you should feel comfortable saying things and being, especially if it could potentially lead to an adverse event. Now, all we did was rethrow the stitch and we were fine. But you should feel comfortable in that situation. Yeah. Any questions?
Good job.
Thank you.